Now we are going to do a panel discussion. I'm going to introduce our moderator. Dr. Sudha Kodali is Associate Professor of Clinical Medicine at Houston Methodist and Medical Director of the Liver Tumor Program at J.C. Walters Transplant Center. She specializes in transplant hepatology, hepatocellular carcinoma, cholangiocarcinoma, and fatty liver disease. Dr. Kodali is committed to advancing multidisciplinary, patient-centered care and improving outcomes for individuals affected by complex liver diseases and liver cancer. And I want to give her a special shout out because without her, this would not have been possible today. For us to do an HCC Lunch and Learn, we have to have a doctor that champions these events. So would you give a warm round of applause as we welcome Dr. Kodali over here? And now if you have a question, raise your hand and I'm going to bring you the microphone. So this is an incredible opportunity to ask this panel questions.
Thank you, Andrea, for that kind introduction. Good morning, everyone. Really nice to see a lot of familiar faces and some new faces. I've met some of you. I look forward to meeting most of you throughout today. Thank you to the speakers and for being here and presenting your expertise. I think all throughout the day, the focus is going to be patient education, advocacy, and how can we get everyone to get more aware of liver disease, because there's a huge burden of this in the community. And knowing your risk factors and advocating for yourself and your family members is going to be extremely, extremely important. With that, I would like to get started with some questions I wrote down, but I really want you guys to take advantage of this. So Andrea, go ahead, and then in between, I'll ask some questions as well.
I have a question. I go to a rheumatologist every 6 months and my PCP, and they're checking my liver panels, and they say they're slightly elevated, my AST. And I wanted to know, should I have them testing for liver cancer?
That's actually a great question, and that goes with what I was going to ask Dr. Galati. A touch of fatty liver, a touch of LFTs. I love that, every time you bring this up, and it's so important because this is what maybe the most common complaint that patients talk about when we see them in the office is like, oh, well, for like last 10 years, 20 years, I've known that my numbers have been elevated. Could you please answer this question?
So I would say all of us sitting here and others in the audience, we have a little bit of a jaded look at all this because we see patients that are just so sick and at the later stages. And so we have the luxury of looking back at old records, be it a year, be it 5 years, be it 10 years, and you see things that were early warning signs that were just not picked up on. And so to your point, that slight elevation of your liver chemistries, the ALT and the AST, even if it is 1 point above normal, that should trigger further evaluation. I would say, at least an ultrasound to see that the liver's shape, size, density looks okay, and then other screening tests to determine what else you may be at risk for. Are you overweight? Do you have diabetes? Do you have high cholesterol? Do you drink too much alcohol? Do you have hepatitis B? Where in the world are you from? You may have certain risk factors. So I would say, even though you feel okay and your primary care or even other specialists are saying, don't worry, just a touch elevated, I'll see you next year, I don't think any of us here would say, yeah, that's a good idea. I mean, David?
My thoughts are similar. I think if there's an explanation from your doctor for why your labs are elevated, then that's a reasonable reason. But if they say, well, that's probably okay, that's probably not an adequate reason. So I think that further testing, if they do not know that your liver enzymes, because your liver enzymes can come from other things. Your AST, ALT can be elevated for other causes. At my office, all roads lead to the liver because I'm a liver specialist. But that's not always the case. So I think the important part is that you advocate to answer why. If they say it's okay, we do not see cirrhosis, we do not see liver cancer, we do not see any severe damage that explains this, then watch it. But you should be your advocate. And I tell my patients to make a graph of your labs and follow them. If they're changing, that's a problem. Okay? Dr.
Great
Egwim?
advice. And I saw a question over here.
Hello. Thank y'all for coming today, and I appreciate everything today. So I come from a background as a prevention specialist, and I would like your opinion based on your experience on how do we convey the importance of fatty liver disease, or I'm sorry, HCC, because I mean we can all think of individuals that we know and people that we love, and how do we express it to them without using layman's terms, but like without seeming like a know-it-all or someone who's just because my thing is I love people in my family, and I know my grandfather died from cirrhosis of the liver. I know my best friend died at 36 from cirrhosis of the liver. But then you see all these patterns of between PTSD and a trauma that's never been treated. How can we get to people when they're mid getting to decide what kind of quality of life they're going to have? Like, what has been the most impactful in your experience? Thank you.
So I'll start and then I'll let somebody else. I think that this is the real challenge because the liver is a virtual experience. If it hurt, my job would be so much easier, but it does not. So I describe liver disease and advocacy for your liver as the idea that your car engine isn't something you worry about until it's a problem. But if you don't maintain it, it doesn't work. So I think that preventative maintenance should be thought of as your regular visits. As Dr. Egwim emphasized, regular understanding of inflammation is important. And our current biomarkers are all blood-based. So if you're waiting on a symptom, you may wait too long. Especially if you talked about family or friends, asking them, and I work for one of the organizations that we talk about, do you know what your ALT is? If you can tell me your ALT is normal, which for a woman, normal ALT is a 19, and for a man, we say less than 27, 30. If you know that that's normal, then you're less likely to worry about liver inflammation, which drives all of this. So I really encourage you to know who you are from an objective space.
Can I just add another, I guess, important point, and please elaborate on that as well, is can you also speak about, mild elevation, it's okay, or even normal labs in a patient who has risk factors, especially diabetes? Those patients need to pay particular attention to their liver because their transaminases, the AST and ALT could be normal all along, but if they have fatty liver, those patients are at risk. So can you please highlight that aspect also?
Yeah, so this has been the reason that we've tried to increase our education, not just to patients and the community, but also to our colleagues in the primary care space, because yes, a patient may have risk factors for liver disease and may have normal liver enzymes. A patient may have cirrhosis with normal liver enzymes, because the liver enzymes indicate inflammation at any one time, but a person may have had inflammation going on for years and years, all the way to developing advanced fibrosis and cirrhosis. And at the time they have their lab work drawn, they may have a normal ALT, AST. And so really, we're trying to get the message out, not just to patients and families, but also to the providers as well. And yes, that issue of no symptoms, it is a drawback. Like Dr. Victor said, if it caused pain, like the rheumatologist, with joint pains, we'd have our offices full. And so you really can only just advise, right? It's like a silent killer. Patients, we've seen patients who've come in with advanced liver disease and liver cancer who somebody told them they had fatty liver disease maybe 20 years before, but they were told, don't worry, it's just fatty liver. Do you drink? Oh, you don't drink? It's just fatty liver, don't worry about it. And now 10, 15 years later, they're here in our office. And so that's really is the best you can. You can't drag them there, but just continue to advise them properly.
Yeah, I've got sort of a little bit of a weird approach with my family. So between my wife and my kids, my siblings, my nieces and nephews, and even sort of this extended family that we've got. Twice a year, we have, Saturday blood pressure day. Now, it sounds crazy, but I will send out a text message to the people in this group, and they're all pretty much healthy. None of them really are suffering from any serious chronic disease. And I will say, okay, Saturday morning, we're all taking our blood pressure and report it back. At the same time, once a year, I'll see to it that, have you gone to the doctor and gotten your blood work? And then we sort of have this big share. Now, this is like against HIPAA and everything else like that. But these are all family, relatives, nieces and nephews that, are getting to the point where they may be developing some, problems. So, it's Uncle Joe, who's like the pain in the neck with everybody, but they know that it's from a loving standpoint. They now have kids and they have to be, careful about what they're doing. And I get no resistance. Now, I think they're just kind and they just listen to me, but that's the way I do it in my family. So you could, just think of it that way, that you're doing it not to be a pain in the neck to them, but just to enlighten them and say, hey, let's all stay healthy as a group. It's not, I'm doing one thing, but I'm telling you to do something else. We all sort of do it together.
I want to add to that, just as a patient advocate, ultimatums work really well too. I actually told my husband I wouldn't marry him until he got a colonoscopy because he had just never had one. And it worked. But he is very grateful because his mother, who's 91, is now dying from stage 4 colon cancer because she never in her life got a colonoscopy. She was one of those people who was very proud that until she was diagnosed with colon cancer, she had not been in the hospital since she had given birth to my husband 65 years before. And she was very proud of that fact. But so I just agree, like if you can make it fun, if you can make it engaging, but also to quote a doctor I heard once, he said, people hear fatty liver and they don't really care. They hear diabetes and they may not care. They hear cancer and guess what? They care. Then they really care. And we have a question here from one of our amazing volunteers, Philip.
So I'm torn between the two ends of the spectrum here. I am a patient. I am currently a survivor, and I fit very close to the profile that you presented a moment ago of the 72-year-old woman. My gastroenterologist detected fatty liver through a biopsy 7 years ago. And forgive me, I really like him, but I have to say this. In his own gallows humor, after the biopsy, he said, I have good news and bad news. The bad news is that you're going to die. The good news is that you're not going to die from this. And 7 years later, it had grown from a small lesion to 5.5 centimeters, and another biopsy turned out to be HCC. So he now regrets very much saying that to me. So I'm torn between the whole, not the diagnosis, but the leading up to the diagnosis, the mitigating factors, the combination of things, diabetes, obesity, fatty liver, et cetera. And how do you get education out there? And I appreciate what everybody says here in their stories. And then the other end, I have been treated with an injectable radiation, Itrius 90, and it apparently has been quite effective. Now, I live here in Houston, but I'm not part of any of your operations. But I'm still on the list for resection or possible transplant. So now let me jump to the end. I really want to know about your experience on resection versus transplant as a survivor of this kind of disease. Where do people go? What is the end result? Obviously, transplant is pretty curative, but it carries with it a lot of other issues, risk, maintenance, et cetera. Resection may not be possible with everybody for a variety of reasons. I'd like to hear some comments on, where do people go with those two options?
So first of all, thank you so much for being here and sharing your story and for your questions. Our second session is all about your question. We have our surgeon, one of our esteemed surgeons, Dr. Simon, standing back there, who's going to talk about options, resection versus transplantation. So we have a 20-minute talk. So she's going to cover a lot of that. And we also have Dr. Hancock sitting back there, who's going to talk about interventional radiology approaches, Y90, TASE, ablation, et cetera. And so we'll hear his perspective as well. And then, of course, Dr. Heine. So not wanting to disregard your question, but we will definitely come back to that. I'm wanting to see if there's any other questions. And while we...
Well, let me speak to just the front half, which I think is kind of the scope of ours. What would, and I'd put it kind of back to you a little bit, and I do this with my patients that haven't been seen by their gastroenterologist or been told they have fatty liver. I remind them that the liver is not a static organ, that time passes, that inflammation, irritation swing back and forth, and that the advocacy for yourself is, as we all talk about, a continuous goal. Joe does it with his family every 6 months. I don't do it with my family, so I'm kind of feeling bad. But I do think that you should continue to advocate for yourself. And the idea that inflammation comes and goes is important. You are not a static diagnosis. So if someone tells you an answer, continue to ask if that's correct and advocate for yourself to be as healthy as possible.
I saw a few more questions. There he is. Okay, hold on.
My question is directed to Dr. Victor. I'm a bit curious. The patient that you mentioned earlier, in fact, I work in the lab for Harris Health, and oftentimes we get back a clean bill of health testings, especially the biomarker AFP. And if those, especially the biomarkers and the precursors, such as the liver enzymes, are, say, normal, what other symptoms, or, well, first of all, you said there are no symptoms, but can we definitively say that the person is free from HCC because the biomarkers or the liver enzymes are showing normal on the lab results?
So if a doctor tells you 100% they're wrong, because we are all here to identify an individual. But when we talk in species like this, it's in percentages. So with patients with fatty liver disease, they have a small risk of developing cancer independent of having cirrhosis, but the majority of cancers start with cirrhosis. So if you're non-cirrhotic, that's the biggest piece. Now, cirrhosis, as you've heard, doesn't have labs that are associated with it. It's a scar tissue from inflammation that can have normal labs. So I think that it's important that in all patients who have cirrhosis, that they undergo the screening that Dr. Egwim talked about, and the diagnosis of cirrhosis should be your first step. Second step is inflammation. So that's manifest in blood tests. The hard part here is without symptom and without being able to do a palpable mass, which for breast cancer, testicular cancer, they have exams that you can do for yourself. The advocacy is through imaging and asking. Do you all agree?
Yes. And I'll add to that, yes. So like Dr. Victor mentioned, there's no perfect test. And so a lot of things that we do are dictated by the risk that that patient has. And so this is the other important part, is that if a person has chronic liver disease, they should be followed regularly. And that alpha-fetoprotein, as Dr. Victor mentioned, is combined with imaging. So we do recognize that patients may have HCC but have a normal AFP, but we have that with imaging. And then there's follow-up imaging. And so one of the problems we see sometimes is that patients leave the office with the message that I'm good right now, and then some don't show up for years. Or by the time they're coming to see us, they were told they were fine 2 years ago, probably told to follow up, but they did not. And so if a person is maintaining that follow-up with their physician, then there is that regular screening for those who have cirrhosis that will occur, so that if it's a small lesion, maybe it's grown and shown on the ultrasound, or the alpha fetoprotein is rising, things like that. So I really just want to emphasize the part of staying and maintaining that follow-up is of great importance.
We have time for 2 more questions, and they're already taken by people, and then I'm going to have you close it out, Dr. Kodali. If you have questions about treatment, please save them for the next session, and you can look on your agenda.
Good afternoon. So I have a question. My husband died from the liver disease, and I was told that it might be hereditary. And so I have children. You talked about getting screened 18 and older. I have younger children. So what would you recommend for younger children, 14, 15, up in that range, that it may be hereditary in the family?
Well, there are certainly liver diseases that are more prone to the younger group, to the pediatric population for sure. I guess, do you know exactly what you have? Well, I would say you'd have to look, for the younger pediatric adolescent, you have to say, just in general, are they healthy? Are they having any symptoms? And going to the pediatrician if they have any, screening, basic liver chemistry, blood work, their CBC, what risk factors, are they overweight? Are they consuming alcohol even at a younger age? And just look and see, are there other cousins, relatives that may have a similar type pattern or different symptoms that they may be having, and look for those basic sort of trigger points that there may be something wrong. But if there is some strong family history, I would say just get some basic liver chemistries. If anything's abnormal, then you have to go down the path of getting an ultrasound and a little bit more detailed evaluation. But well, I would think it would depend on if you discovered anything, then it would need, a more regular follow-up. If you do the initial screening, maybe even for some of the genetic testing or hereditary type things, and they're negative, then you might be able to slack off a little bit on the follow-up. But, it's an imperfect science in a sense, but you just need to be, really clinically curious on the side of the providers of what might be going on here.
I would advocate that you talk to your pediatrician and tell them why you're worried. Most kids are okay. Most people are okay. These are rare diseases we're talking about today. But if you're concerned, express your concerns and say you want to make sure that there is no objective inflammation markers. We've talked a lot about inflammation because it's what we have to go on as an early marker at this point.
Okay, one last question, and then we'll have Dr. Kodali finish out session 1.
This is for Dr. Victor. You were talking about your test results. I do have mine, and my doctors keep telling me that it's a fatty liver. And I noticed that my AST is always between 32 and higher, and my ALT is 27 and higher. And I want to know, is that something I should be concerned about to go ahead and be tested? And I've already had the hepatitis A and B vaccine.
So it's a hard question to look at real numbers on an individual, but let's say that the normal for a woman is an ALT of 19, and that chronic inflammation over time, if that is coming from the liver, is not perfect. So I would say, hey, this is bothering me. Should I get an ultrasound? And that's where I would start individually for what your question you're asking. Is there anything wrong today? No. But like a liver, like if you think of the liver like a car engine, and if an engine is running at 110 degrees and it should run at 100, that engine is probably not going to last the 300,000 miles you want it to. So thinking of it in that fashion, there's nothing acute, but could you do more?
Okay, just because I have the microphone, I'm going to take the liberty of asking one last question, 30 seconds to respond. And this is a very sensitive question. It's extremely important. Alcohol safe limits, multiplicative effect on liver disease, and myths, because there's a lot of cardiology. Oh, my heart doctor said it's okay to have a glass of wine or two. And then we're talking specifically in the context of this huge burden of fatty liver, metabolic liver disease, add alcohol, lifestyle, and then we're looking at what does that mean. So we will say we are at 11:28, so maybe a minute, please.
All right. So my 2 cents, and I'm not part of the anti-alcohol lobby in any way here. So the guidelines are for men 2 standard alcoholic drinks, which is essentially a can of beer, a glass of wine, not these giant pours that you get at your favorite restaurant, and a shot of distilled spirit, one for females. Now, the Surgeon General about a year and a half ago came out and said that might even be too much. But to Dr. Kodali's point, there's millions of people walking around with fatty liver. They know it, they don't know it. There are still people today walking around with hepatitis C. People still walk in, people in their 50s that have had hepatitis C for the last 30 years, and just now they're getting diagnosed. So a lot of the times people don't know what they have, and they're consuming. Even small amounts of alcohol could be quite damaging, accelerating the inflammation, which will accelerate scarring and accelerate cancer. So first, know what you may have. I think from a consumer standpoint, I think a lot of young people are being bombarded with so many different alcohol infused drinks that look very cool. They're in neat little cans and bottles. And there is some concern that especially younger women are increasing their alcohol consumption, which all in all is just leading to a colossal number of health-related problems.
There is no safe amount of alcohol for the liver.
Say it one more time.
There is no safe amount of alcohol for the
What'd you
liver.
say?
There are other factors by which you might choose to consume an alcoholic beverage, but none of that is beneficial to the liver itself. It is not helpful to the liver. There is very limited data that alcohol from red wine in very small and has been refuted in other studies that it may have some benefit, but alcohol should be used as a
I know, I'm just going to, what did you say?
I can't come up with a positive word. You should choose to use it because you choose to. It is not helpful to your liver in any way, shape, or form. But I can't tell you, because there's no risk counter, how many drinks you can have till it's a problem. There are people who've never had one who have cirrhosis, and there is Keith Richards. So there are a spectrum of people, and I don't know who you are, but if you want to know the risk, every drink is a risk.
Okay, Dr. Egwim.
And I'll just add to that, there's so much we don't know about disease formation and risk, where you have 2 people with the same exposure and one develops a disease and the other does not. And so it's all about risk reduction. We don't know what factors lie in us that will make us at a higher risk, which is why our diet, the exercise, limiting the alcohol use, they're all very important. We can't consider ourselves like in isolation, this one factor. So just as my colleagues have said, it's all about the risk reduction. That's important.
Well, I guess in interest of time, we're going to conclude this first session. I really am extremely grateful that you all came here today. Great conversation.